Good morning, everyone. Thank you for having me in this outstanding conference. My case today is seeing is not always knowing, critical left main dilemma. My patient is 44 years old male, diabetic, has a prior history of multi-vessel PCI, presented with acute cry syndrome of in the form of accelerating angina of 5 days duration. His initial workup was inconclusive. His biomarkers was negative. His echocardiography showed ejection fraction of 45%, hypokinetic inferior lateral and posterior wall. So we proceeded to coronary angiography. Here in the caudal views, you can appreciate the presence of a critical left main with a pressure damping. In the cranial views also, we have the same critical left main, ostial left main, and another lesion in the OM and the ostial ramus intermediate. So the RCA, the coronary angiography showed patent stent as well as another patent stent in the LAD. Well, the key finding in our patient, he has a critical ostial left main with pressure damping. He has ostial ramus intermediate. He has a significant OM. So now what should we do? Should we refer the patient for surgery? Should we intervene for the left main? And most importantly, what does the guideline says about this situation? We move to our heart team discussion. The dilemma is we having an ostial location of left main, pressure damping, and most importantly, non-coaxial Judkins catheter, which is always used mostly routinely in all cath lab for diagnostic. So we decided to exchange for more coaxial catheter, in our case with the XB1, and perform IVUS RAM for definitive assessment. And here's the truth. The polygon of confluence has an area of 16.6. The body of left main has a capacious area of 15 millimeters square, and the ostial left main has an area of 9.8 millimeters square with black burden of 30%. So our IVUS deferred the surgical option and left us with 2 lesions. So we decided to IVUS the ramus intermediate first, as we thought it is mostly the culprit one. We tried to pass the IVUS probe, but it didn't pass, so we performed PTCA, and eventually we passed the IVUS. You can see he has a critical lesion, a partially calcified one. So now what is the plan? Should we intervene for the ramus intermediate, or should we intervene first for the OM? If we intervene first for the ramus intermediate, we are risking jailing the ostium of the LCX. So we decided on the side branch first approach, performing BCI to OM, followed by the ramus intermediate. We passed 2 wires, BMW wires, one in the ramus intermediate and another in the OM. We redilated the lesion, then stented the lesion successfully with good angiographic result, and the IVUS showed a very well opposed stent, very well deployed, with no distal edge dissection. Then we moved to the BCI to ramus intermediate. We previously dilated that lesion, so we proceeded to the stent. We tried to adjust the stent exactly at the ostium to minimize the risk of jailing of the LCX ostium. And we performed BOT, and this is the IVUS of the deployed stent, showing well deployed, well opposed stent. And here is the final angiographic result. So our intervention summary, we had a 1.1 gray radiation, contrast of 200 millimeter. Procedural time was nearly 40 minutes. The patient has an uneventful recovery, discharged on DAPT and maximal medical treatment with complete resolution of angina. So our key learning point is following. Lesion angiographic left main can be misleading, and we should always verify with IVUS. Catheter selection, XB over Judkin, enhance image quality and safety. IVUS guidance improve stent optimization and reduce restenosis. And sequence of PCI matters. treat the side branch first when geometry risk exists. I want to thank everyone and thank my hard team, colleague, and cath lab team. Thank you.